Every clinical prediction model makes structural assumptions. Apache scores assume that specific physiological variables predict mortality through a particular additive structure. SOFA scores assume organ failure compounds in a specific way. Calibrating these models to patient populations is not the same as validating their structure. A model can predict well in the population it was trained on and still be structurally misspecified. The confusion between calibration and structural correctness is the origin of model risk in clinical medicine. Logistic regression assumes that the log odds of an outcome change linearly with predictors. For clinical deterioration that follows nonlinear thresholds, this structural form is wrong. The model can appear well-fitted in patients near the mean of the training population. But for patients near clinical extremes, the structural form fails systematically. No recalibration of the coefficients corrects the nonlinearity. The failure arrives precisely in the patients who most need accurate predictions. With more patient data, parameter estimates improve. Coefficients become more precise and confidence intervals narrow. But if the structural form of the model is wrong, linear when the biology is nonlinear, more data does not fix this. More observations reinforce the wrong structural form. The model becomes more precisely miscalibrated for the patients whose physiology violates the assumed structure. Parameter convergence and structural correctness are independent properties. Treat-to-target protocols optimize clinical interventions against a model-defined goal. If the model relating treatment to outcome is structurally wrong, the protocol optimizes against the wrong target. The more tightly the protocol is implemented, the more precisely harm is delivered to the patient. This is structural amplification in a clinical context. High protocol fidelity inside a misspecified clinical model does not improve outcomes. It worsens them systematically. A clinical prediction model can achieve a high AUC and still be structurally wrong for specific subpopulations. The C statistic measures overall discrimination on the validation dataset. It does not measure whether the assumed structure holds across demographic or physiological subgroups. Two models with fundamentally different structures can produce indistinguishable AUC values on the same cohort. For patients from different demographic groups or with shifted physiology, structural failures emerge. In-sample validation cannot resolve structural uncertainty. A novel pathogen or a new treatment paradigm constitutes a clinical regime change. Models trained on prior patient populations may be structurally wrong for the new clinical reality. COVID-19 demonstrated this clearly. Existing severity scores performed poorly on novel pathophysiology. Model risk in clinical medicine is managed by structural humility, not by reporting model performance. Structural humility means maintaining multiple clinical hypotheses and preserving optionality when regime change is possible. Treating a clinical model as true eliminates protection against the patient you cannot see.